Welcome to another episode of Ostomy and IBD Life. My name is Elaine O'Rourke. I am your host. I myself have had my ostomy for 15 years, my ileostomy due to Crohn's disease. So this is a place where we can discuss all things about Crohn's, colitis, having an ostomy, from the physical to the mental to the emotional issues. This week's topic is women's health with IBD and an ostomy, from fertility, pregnancy, and sexual function. So I'm really excited about this. It's a big topic, and I am honored to have Dr. Sonia Friedman join me this week. I will introduce her in a moment. But first of all, I like to say, if you are watching, please put up a comment. Let me know me on YouTube, Elaine O'Rourke Yoga, Ostomy and IBD, or else on Facebook on my Ostomy and IBD Life page, and on Instagram under Elaine O'Rourke Yoga. So without further ado, let me bring in Dr. Friedman. Welcome, Dr. Sonia Friedman, into this week's episode. I'm delighted to have you join us.
Thanks for having me. It's great to be here.
And so Dr. Sonia Friedman is a distinguished IBD clinician, researcher, and teacher who is an expert in IBD and women's health issues, as well as the director of women's health at the Brigham Women's Hospital here in Boston at the Crohn's and Colitis Center. She is also an associate professor of medicine at Harvard Medical School. And I have been honored to have Dr. Friedman as my own Crohn's doctor for many years when I was going through Crohn's. And you have helped me tremendously over the years. So thank you so much from the bottom of my heart for how much you helped me and put me in the right direction and helped to inform and educate me on my journey through Crohn's disease.
Thank you so much.
So we have a big topic this week, women's health issues. So Dr. Friedman, let's just delve right into it. First of all, if you could let us know, like, how does IBD affect fertility for women?
Well, most people with IBD have normal fertility. So most people with Crohn's and colitis have normal fertility. The exception is, if you've had Crohn's disease and you've had surgery, especially pelvic surgery, where the anus and rectum are removed, because you can get scarring of the fallopian tubes, that can impact fertility. And especially in ulcerative colitis, if you've had an ostomy or a J-pouch, that can impact fertility. But otherwise, fertility is pretty much normal in Crohn's disease and ulcerative colitis.
Oh, right. So then for girls that have, that grow up having Crohn's or colitis, and with getting your period or not getting your period, how does IBD affect that, your period, your cycle, and how does your cycle affect your IBD?
Right. So it's a big issue. Girls just getting their period. If they're underweight, if they're not eating right, the period could stop or take a longer time starting. So that can sometimes be an issue. So you have to make sure patients have really good nutrition to get their periods. It's actually a sign of how sick somebody is. And many people will flare during the menstrual cycles. So their IBD symptoms can become worse just hormonally. And so many women ask for a way, like birth control pills, or a way to make their periods a lot better. So their IBD will be better around their periods. And the other thing is, which is interesting, is that endometriosis is associated with IBD. So sometimes they're kind of linked together. So there's a lot really about menstrual cycles and IBD, and I think a lot more research needs to be done.
Yeah, that is fascinating, because that's information that I was not aware of. Yeah. And I would just like to say from my own personal experience that I never had any issues in regards to my period, but I also never wanted to get pregnant. So it was something that this is a topic that I never had to really delve into. I mean, I do remember, you know, it was probably with you having a conversation when I was going to get my ostomy as to like how that might affect things down the road. But, you know, I always just knew I didn't want to have children, but it is something that I feel that goes through a lot of women's minds. Just in that regard, I do also know that for some people, when they get pregnant, that they can go into remission.
Right. So just to kind of back up on the fertility a teeny little bit, I don't want to discourage people from getting surgery because IVF works really well in IBD. So I think that if you need surgery for IBD and it's going to make you feel better and have a better quality of life, you should absolutely go ahead with it. You know, there's new surgical techniques, you know, laparoscopic surgery and that open surgery that really improve fertility. So I think it's really, you know, the odds, you know, the fertility is a lot better these days than it was 20 years ago. And, you know, in vitro fertilization does work extremely well. So definitely talk it over with your doctor because it isn't, I mean, there's definitely potential to have, you know, to get pregnant, have a normal pregnancy if that's what you would like to do. And then you asked me about, I'm sorry, what was after that?
Oh, then I was also, well, I kind of jumped the gun a little bit, actually. Let's just get back to this with the fertility. What about then, so most people who have Crohn's, colitis are probably on some sort of medication. So how does the medication affect getting pregnant, or what side effects would there be, or dangers that there would be in regards to taking different drugs?
Yeah, I mean, that's such a big issue. So many people worry about medications in fertility and pregnancy, but really most of them are very safe during pregnancy. And the main thing to remember is you want to be in remission when you're trying to conceive and have a pregnancy because you'll do a lot better on any number of these medications, and I can go through them as long as you're in remission. So disease activity, you know, a flare matters much more than being on any of these medications. You know, for example, I mean, I can go through the medications: infliximab, adalimumab, certolizumab, vedolizumab. All the biologics are safe during pregnancy. You know, azathioprine, 6-MP are safe during pregnancy. So usually we continue women on these medications as you know, if they're in remission going into a pregnancy, and there's not a lot of toxicity at all. Women can nurse on most of these medications as well. So you know, people do a lot better staying on their medications.
Oh, right, that I didn't realize.
Yeah.
And then, so it being in remission, how long do you suggest a woman to be in remission before considering getting pregnant?
We just like 3 months, you know, 3 months of a stable remission on stable medications. And, you know, we're seeing patients pretty frequently. So I always have this discussion with people. And, you know, I think we do pretty well. So I think people, you know, take medication and do pretty well as long as you give them all the information that these medications are safe. I found my patients, you know, pretty receptive to staying on them, you know, throughout conception and pregnancy.
All right. And then would most women, if they are, you know, getting pregnant, then do you actually work in conjunction with their GYN team? Or like how much crossover is there these days?
There's like a ton of crossover. We work with a very specific team. This is our hospital. I mean, I would imagine it's like this at many hospitals too, but we work with the maternal fetal medicine team, and they're very experienced in Crohn's disease and ulcerative colitis and these medications. So we go back and forth a lot. We, you know, talk to each other a lot about, you know, patients and their pregnancies and deliveries. We also have a team of infertility specialists. So if someone has trouble getting pregnant, we'll send them to a particular team of specialists, you know, inflammatory bowel disease, who are aware of all the issues. So I think I'm just very fortunate because my hospital has a really strong OBGYN program. It's unique.
That is fantastic. And again, that's something that, when did that start, Sonia? Is that been in the last, because as you know, I've been I've been thankfully away from the medical medical field for the last 14 years. So, when did all of that kind of like gel in say the last 15 years?
Yeah, maybe like 15 years, and they've been working with these particular doctors for a while. And basically, we know each other really well. We've been here a long time, and our group refers to their groups, daily, I would say. So
that is fantastic because, we are very fortunate in this area. We are in the Boston, Massachusetts area. There's amazing medical facilities. But what would you suggest to someone who maybe doesn't have such good access to great medical hospitals and facilities?
Well, that's such a good question. There's actually national guidelines. They're called the Parenthood Project. And it was a group of doctors and nurses and epidemiologists that got together to draw up guidelines for IBD and pregnancy. And that was for healthcare providers, that weren't specialists, that were in remote areas. So it's called the Parenthood Project, and it's a set of guidelines, and you can find it on the website of the Crohn's and Colitis Foundation. And in fact, if you go on the Crohn's and Colitis Foundation website, they have information on all of this and the doctors that you can contact in your area as well.
Oh,
so
that is
really helpful.
So the Crohn's and Colitis Foundation, so I believe that's crohnscolitisfoundation.org, if I am correct. But if anyone is wondering, just Google that. And I know they have a ton of amazing information on their website. Sonia, could you just say the name of, what was it?
It's called the Parenthood Project. And if you just Google that, there should be a lot of information too.
The Parenthood Project.
Yeah.
Fantastic. So then in regards to, because I know a couple of people that I have talked to that said once they got pregnant, that they actually went into remission maybe for a number of years after, or maybe just complete remission of their Crohn's or colitis. How common is that, or do you have any theory as to why that would be?
Oh, if I knew the answer to that, I mean, I could win like a Nobel Prize or something. No one really knows. Probably when you get pregnant, the disease is calmer after, but there's still more research that needs to be done. So if you go into a pregnancy in remission, there's a 2/3 chance you'll stay in remission. If you go into a pregnancy with a flare, there's a 2/3 chance you'll flare. So the main thing is to be in remission before pregnancy. Women with Crohn's tend to flare less than women with ulcerative colitis during pregnancy, which is strange, and no one really knows why. It has to do with immunological phenomenon that people are investigating now, but no one really knows why. But the best bet is to be in remission, before you start a pregnancy.
Right. Then, so that's really fascinating.
Yeah.
I wonder, so like the whole like the hormones for women is a huge big topic, and I know we weren't really planning on talking about this, but even going towards like the menopausal years, what sort of effect does that have on women with Crohn's colitis? Have you found?
No one does a lot of research on menopause. Surprise, right?
Mm-hmm.
There's not a lot on menopause and IBD. So no one really knows, in terms of the hormonal mechanisms, but menopause does not make IBD better. That we know. Okay.
Well, I would imagine just that extra heat in the body, because like a flare up is just kind of, it's like that red, that anger, just that ulceration, and kind of like, that's kind of like a lot like menopause.
I mean, so like, I haven't seen a lot of research on it, but it doesn't seem to make IBD any better. It doesn't seem to make it any worse. The other issues with menopause are osteoporosis, and then other screening stuff for like colon cancer, because people are older and they need more screening and stuff.
Right. So then in regards to, someone with an ostomy, so again, for anyone just beginning to tune in, we're talking about women's health with IBD, ostomy, in regards to fertility, pregnancy, and sexual dysfunction. So I know for myself, when I was, well, let me backtrack. Let's get on to something else before we go into the ostomies. I know when I was really sick, I had like my disease was fistulizing through the rectal area. And I was so weak that there is absolutely no way that I would be doing anything in regards to any intimacy with anyone. All I could do would be receive a hug. But in regards to the sexual function with women with Crohn's and colitis, let's start with that first. I know you've really done a lot of work with bringing up this conversation over the last number of years, because this was never, I don't think I was ever asked anything about this in all the years of having Crohn's disease. So I'm really delighted that you are really bringing this to the forefront. How common is it for women to have sexual dysfunction?
So the reason we started being interested in this is that we had read a little bit about it, and then we just started asking our patients in clinic about sexual function. And I thought they'd be shy and not talk to me, but everybody was so passionate about it, and so many people were having problems, like both men and women. So me and my colleagues were like, wow, this is really a problem. So we sent out a lot of questionnaires, and we tried to see where the problem was. And then I did more research after that, on men and women. And I'd say up to 40% of women, or maybe more. Some numbers put it up to 50 or 60% have problems. And the main issue with women is dyspareunia, and that's painful intercourse. That's the main issue with women. The other issue is inability to achieve orgasm. And that's research that we did in Denmark. Women had answered a sexual function questionnaire, and it was women with Crohn's disease and ulcerative colitis compared to women without those diseases. So, but I'd say the biggie is dyspareunia, which is painful intercourse. And there are many reasons for it. I don't know if you want to get into that now, but there are many reasons. Yeah, the first is surgery in that area, like fistula surgery, anal rectal surgery, abdominal surgery in the pelvic area can cause painful intercourse. Depression's a biggie. So a lot of people with this problem have depression. Increased disease activity. So inflammation can also cause this problem. And it can be really helped through pelvic floor physical therapy. So most women who go through that, it's a pretty intense process, like weekly physical therapy, have a ton of improvement. So if that's an issue, I would strongly encourage you to pursue that.
Yeah, and I'm really glad that this is also being brought to the forefront about pelvic floor therapy, because this was also something that was never discussed, and hopefully some week in the future I will have someone on to talk about that a little bit more, because it's just so valuable to be able to get help in this department. I know when I was going through, as I was saying, when my disease was really fistulizing, there's no way, I wasn't in a relationship at the time, but if I had, the level of discomfort that I was experiencing, and plus even after I gotten my ostomy, the whole rectal area, it's was very uncomfortable. And that affects the vaginal area as well. So it is a real issue for people, and to be able to discuss it with others is really valuable. So if you're watching this, if you're listening to this, and you want to reach out to me directly, then please do, because I do have experience with some of this for sure. And also then, Dr. Friedman, in regards, is there any other, do you feel that any of the drugs affect sexual function?
So steroids can affect libido, narcotics can affect libido, and antidepressants can affect libido, but it won't cause pain. It won't cause painful intercourse. It's mainly the surgeries, the disease activity. Depression can affect libido mainly. And of course, you want to go to your gynecologist just to make sure you don't have anything else wrong, physically wrong, like a yeast infection or, some kind of infection or inflammation there, so that it isn't treatable easily with medication. So, because
right.
there are many causes,
Right, because a lot of the time you can be on, I know I was on antibiotics,
right,
on and off for long periods of time, so that can cause yeast infections and just imbalances as well, so that can be easily rectified also. Right. So then I'm just going to check in with the comments just to see if we have any questions so far. Oh, we got lots of people watching. Hi, Anita, Nurse Anita, and Justin watching. Oh, and I will be bringing on, guys, if you're watching, don't worry, I will be bringing on someone to talk about men's issues also. So don't worry, I haven't forgotten about you. Francine is watching. Hi, Francine. Oh, yes. And so Anita brings up a point of the fear also then of fecal leakage, which is, I mean, obviously if you have disease, you're running to the bathroom all the time. So that is quite a big concern for people of not having control. Does that come up a lot for you? Do you hear that a lot, Sonia?
I mean, when we were developing a sexual function questionnaire, that was a biggie. Many people had that issue. Yeah. I mean, it has to do with controlling disease activity and maybe taking like Imodium, antidiarrheal before sex. But yeah, it was a big problem. And even if it didn't happen, people were still worried about it happening, which is terrible, you know.
Right.
So talk to your doctor about it.
Yeah.
Most definitely help.
Right. And also, just in regards to this, to really like honor, like if you're in a flare up, like you're feeling crappy, right? So you're probably not going to be feeling sexy. So to be able to have that honest discussion with your partner, like if you're in a long-term relationship, being able to talk about that, or if you're getting into a new relationship, to bring up these topics from the start, because this is your life that you're living. And when you're going through a flare up, chances are you don't want to get too sexy. So, you know, you might need to explain that. But who knows, maybe then you're just like, yeah, that's the remedy that you need. So it's very individual. And some other week we'll talk a little bit more about, get deeper into intimacy. So Sarita has a question. I'll just bring this up here so I don't mispronounce. What about estradiol? I always pronounce things wrong. For fibroidsine. Sonia, can you see this message?
You mean like like postmenopausal hormone therapy, or postmenopausal hormone therapy, if that's what you mean? It doesn't have an effect on IBD as far as we can tell. So just use it after speaking with your gynecologist if you need it for other reasons. In terms of birth control pills, which we probably should get into, lower estrogen pills, because IBD flares, you can clot more, you can get blood clots. So make sure you don't have a family history or personal history of blood clots before you start on the pill. And you want a low dose estrogen pill. And especially when you're flaring, you may not absorb the pill. You're more prone for blood clots. So, talk it over with your doctor. But most of my patients in remission are on low estrogen pills, and it's completely fine. Or an IUD for birth control. And in fact, that's the birth control that most GYNs recommend for patients with Crohn's and colitis. And they work great. So.
Oh, okay. That's great. Because I wouldn't have thought about that. For taking the pill. Very interesting. Yeah. So Anita gives it. So in Europe, there are apparently rectal tampons. So that could work. And they're made by Coloplast. So that's, I've never even heard.
We have a lot of better things in Europe. I mean,
yes, I know.
Always.
Europe is a little bit ahead with some of that stuff.
Always.
Yeah. Sonia, let's get back to talking about, and please keep the comments and questions coming in, everybody. In regards to people with ostomies, what about getting pregnant? Is it possible? What should people consider? Can you talk us through a little bit about that?
Yeah, sure. I mean, I'm assuming that you've had a resection of anus and rectum, so you've had pelvic surgery, which could lead to scarring of the tubes, the fallopian tubes. So there's probably less fertility with an ostomy. But, with the newer surgeries, laparoscopy, people do a ton better. And IVF works really well. So there's probably a little decreased fertility, but people in general do well. I never tell patients not to get an operation that they desperately need. in the fear that they won't be able to get pregnant in the future. I think that's just ridiculous. I think people have to treat themselves. And, IVF works extremely well. In terms of the pregnancy with an ostomy, people do very, very well. There's really no issues. Sometimes the ostomy can get a little bigger, but then it'll shrink back to normal. Very rarely, patients can have a bowel obstruction, but that's pretty rare. And in general, patients do incredibly well with pregnancy and ostomies.
Okay.
That's good
great.
news.
I would always, let me just bring myself back in here. I was always thinking, gosh, how do you get to change your ostomy when you got like your big belly and your ostomy down under?
I know, you would think, right? I mean, but I've seen patients, 8, 9 months pregnant with ostomies, and it just gets a little bit bigger, and you may need like a bigger, appliance, but people do quite well, like shockingly well. So
yeah. I know people do it. So anyone, if you're out there, and if you have an ostomy and you're thinking that you can't get pregnant, that you can't go through pregnancy, you can. Please just talk to your medical team and get advice as to how to go through the whole process. And just know that you may need to use different products through that time period. Then with people with, is it possible if you have a J pouch though to get pregnant?
Yeah, I mean, a lot of people ask that question, and especially with the newer surgical techniques like laparoscopic, very small incisions, if you're not completely inflamed before they do the surgery, people do quite well. I mean, there's slightly decreased fertility with a J pouch, but you can get pregnant naturally, and if you're unable, then IVF works quite well. So yeah, we totally encourage conception and pregnancy if people want to. That's like my favorite type of person to treat. So yeah,
I think that is like really comforting for women in general, because for so many people that is really so important for them, and to feel like that they can fulfill that role in their lives. Then is there anything even about breastfeeding with being on different, so like say if you still are on medication, is it still okay to breastfeed if you're
it's a really good question. All the biologic medicines like infliximab, adalimumab, have very, very little amounts in breast milk, like 1 in 200 of the blood levels. So it's extremely safe to breastfeed. And there's definitely studies on this. All the biologic medications, that I can go through them: ustekinumab, vedolizumab, natalizumab, the anti-TNF medications are all safe to breastfeed on. And we definitely encourage breastfeeding. So yeah.
Great. Let's see, is there anything else? Oh yeah, so then in regards to like energy levels, then even nutrition wise, what are you suggesting? Is there any like guidelines? Because again, like 15 years ago, like when I first got Crohn's disease, nearly 30 years ago, there was very little talk about nutrition. That was, now thankfully everything is being a little bit more integrated. But is that, what do you suggest, especially for women who are, looking to get pregnant, in regards to nutrition, and what would be good things to be ensuring that you're eating or taking?
Yeah, I mean, you're so smart to ask about that, because it's so important. You don't want to be underweight. You want to have a normal BMI. You want to eat all your fruits, vegetables, protein. We do check vitamin levels before pregnancy. We don't want you to be anemic. So we check iron levels and B12 and D. We give people a prenatal vitamin. So, I mean, nutrition is really important. I mean, diet for Crohn's and colitis is a whole different topic, and many people have different theories. Diet definitely can make a difference. So we often refer patients to a nutritionist. But I'd say the main thing is we don't want people to be underweight going into a pregnancy. We want them to be a healthy weight. We want them to have normal vitamin and mineral levels and be eating a well-balanced diet. And right. So pregnancy too.
And I think it is like really fantastic, like how far, even, like over the last number of years, how like the Western medicine is really getting on board with the whole nutrition, and even like the holistic, realizing like everything's connected within all of our bodies, and how we treat our bodies, even how we talk to each other, how we talk to our own selves, and just honoring our energy levels as well. I'm going to go back, Sonia. Is there anything else that you can, I know you could talk all day. Is there any other, about all of this, is there any other things that I'm missing asking?
Let me think. Oh, yeah, there's an interesting thing, in women with IBD called voluntary childlessness that I think is really due to the fact that people are not informed well. So when you look at like the papers that have been written and everything, a lot of women with IBD choose not to have children, which is so odd because if you look at like what we've been talking about, women with IBD do incredibly well with fertility and pregnancy and delivery, as long as they're in remission. So there's a high rate of what we call voluntary childlessness. It's crazy. It's like 17% versus 6% in the normal population. So I just want to encourage, patients. I want to encourage you to like talk to your doctor about it because pregnancy is very safe these days. We have really good medications. We have really good technology. We have a lot of experience. So I think like it's very hopeful. And yeah, I really enjoy treating people who are pregnant.
Yeah, I wonder if that's just because, I wonder if part of that is because when you're going through a flare up and you just feel so depleted, it's so hard to look after oneself, especially if you're going into the hospital, that I wonder if some of that is because, and, this wasn't the reason why I didn't want children. I didn't want children because it was always hard enough just to look after myself, regardless of Crohn's disease, but I'm enough to manage. But I wonder if it's because people with that fear of, gosh, I'm in hospital every year. If I had a child, like what would I do? And I wonder if that plays into it a lot, or because throughout the years there's always been a lot of talk that Crohn's it can be a genetic disease, which personally I don't really believe that too much, but some people there is a little bit of genetics, but I wonder if that's part of it. Do you think?
You're completely right. Like people have looked at this, the word they're going to pass it down. They give a much bigger genetic risk than there really is. For adults, there's very early onset IBD, which is different. Kids that get it between the age of 0 and 5, which is genetic. But for adults, for us, it's not as big a genetic component than people think. It's also people are worried about the medications during pregnancy. And that's really education because they're really safe during pregnancy. They're worried about a flare during pregnancy, which we can really help with. They're worried about caring for their child after they deliver, which I can totally understand, and caring for themselves. But I think some of it's education, some of it's true, but most of it, I think, can be overcome, by good care and good medications and education.
Right. Yeah, I think you're right. Definitely. Another thought just popped into my head in regards to women with Crohn's or ulcerative colitis, in regards to maybe having a prolapsed rectum can happen, and in regards to even the disease fistulizing into the vaginal area. Like what can be done about that, or like is that something that someone has to deal with for their life, or is that something that can be helped or treated?
Yeah, you're totally right. It's a terrible complication of Crohn's disease, erectile vaginal fistula. So, the best treatment for erectile vaginal fistula, first line treatment for Crohn's, is really, I think, Remicade, infliximab. That's the generic name, is infliximab, with maybe azathioprine, so dual therapy. It's one of the worst complications that people have. I totally agree. Some people need surgery for it. There are various types of surgeries. In terms of pregnancy with this, if you have it during pregnancy, you'll need a C-section. I guess we didn't talk about modes of delivery yet, which we should probably talk about, right?
Yes.
So that's one of the indications for a C-section, as well as active, fistulas, perineal fistulas, because you don't want an episiotomy or a tear. It'd be like terrible in terms of wound healing. And we also try to shy away from, we call it assisted vaginal deliveries. So a vacuum delivery or a forceps delivery with a big episiotomy, you could also get poor wound healing. So we try not to do that either. But most women can have vaginal deliveries. Most women without fistulas can have vaginal deliveries, just, normal vaginal deliveries.
Now, what about, so if you have an ostomy and you had to have a C-section,
it's tough, yeah.
How is that even possible? Like what do you, I mean, I'm sure it has to be possible because you never know until the end how things are going to turn out. But I would imagine that would be quite difficult.
No, you're totally right. It's because you've had so much surgery in there and adhesions in there, it could become more difficult. So, often we'll have a surgeon on call if someone with a J pouch, anal pouch for ulcerative colitis or an ostomy or lots of surgeries needs a C-section. We'll have a surgeon on call just to make sure everything goes okay.
Right.
But yeah, you're totally right. I mean, with a lot of surgery, you don't really want to do a C-section.
Exactly. Right.
It's a reason why you need a center that's experienced.
Yeah.
We like try to develop birth plans beforehand, and we go through it with patients. Yeah, I think it's really important in terms of what they want. Some women want vaginal deliveries, and I know the obstetricians will try their hardest to do that.
Right. So yeah, just being like getting to the right sort of facility would be just so important for women, if possible, all depending where you are in the world and where you're living. I'm just going to go back to the comments again, Sonia, just to see if we've any other questions in this regard. And just as a reminder, if you're watching this on the replay, that you can still post up questions and I can try and get answers for you. Or if you want to send me any direct questions, you can direct message me through my Facebook page, or you can even go onto my website, which is Elaine O'Rourke. Oh, that's not it. It's ElaineO'Rourke.com, and you can grab my free guide. I have a free guide for people with ostomies called 3 Ways to Eliminate Fears Around Your Ostomy. So you can grab that. And for anyone with IBD, you can grab your free guide called 5 Mistakes Even Well-Informed People Make with IBD. And that just has useful information, but you can also get in touch with me and even just schedule a quick call with me on there. So to wrap things up, Dr. Friedman, any other insight, any other things that we might have missed that's coming to mind?
I mean, just a good resource is really the Crohn's and Colitis Foundation. They have everything about this on there. The Parenthood Project has links for patients. And just remember, most people who want to can get pregnant, have a healthy pregnancy and delivery.
Yeah.
All of my patients who wanted to get pregnant, through IVF or whatever means eventually have gotten pregnant. So
that's really helpful. That is really comforting, I would imagine, for any woman out there that is listening to this and has been worried about this. Know that anything is possible. Keeping an open mind, anything is possible, for sure. So thank you, Dr. Friedman,
Thanks for having me.
Hard to have you on. And it's been lovely seeing you. And as I said in a previous episode, I always love seeing my previous doctors now that I'm not the patient in your office.
You're always a pleasure. It's always a pleasure to see you, really.
And thank you, and continue doing the amazing work that you do. And again, Dr. Sonia Friedman is at the Brigham and Women's Hospital, and she's a clinician there. She's a researcher, and she is the director of women's health at the Crohn's and Colitis Center there. And we're really fortunate that there is this dedicated IBD center, which my sister last week was saying also. I think it just makes such a difference when you have, the people that are just so well informed and educated in this field, like professionals like yourself, that we are just so lucky to have you in this area.
We're lucky to have you.
So I'm going to wrap things up. Dr. Friedman, thank you so much for joining me. And again, if we have questions, we'll try and get
Please,
them.
I'm happy to answer. Yeah.
Thank you. Thank you so much.
Thank you.
And everybody, thank you for joining me again this week for this amazing episode. I hope it was informative to you. Keep the questions coming. Also, you can reach out to me if there's certain topics that you want covered, and I will get someone on to talk about men's health as well as men's sexual function with Crohn's, colitis, and ostomies. So I have you in mind. Don't worry. Next week, I will be here. Next week, I'm going solo, and I'm going to be showing and leading us through some relaxation techniques and stress reduction techniques because it is election day and we all need that. So join me next week. I'll be back again live at 5. That's East Coast America time. Please follow me on YouTube if you can. Give me a thumbs up or subscribe. And you can follow me on Facebook and also Instagram, Elaine O'Rourke Yoga. Okay, everyone, have a beautiful rest of your evening. And I look forward to seeing you again next week. All right, take care.